I'm Neha Motwani. I'm the founder of Luma Fertility, and it's really a privilege to welcome all of you all, here for our inaugural symposium. I'll start with a quick background and the story, what actually led to the journey of Luma. Uh, I'm a tech entrepreneur. I have built, fitness and wellness brands in the past. I created a fitness marketplace called Fiternity, which was acquired by Cult, and the journey to Luma was actually a very, very personal one. I have had 3 years of navigating my own fertility journey. I went through 6 IUIs, 6 IVF cycles, and a lot of procedures in between, which I'm sure all of you all sort of know about. Um, and I feel like when I go back to that journey, I feel like the doctors did their best. Literally, each and every doctor I went to did their best in that journey. But the periphery of the experience of how tough IVF and fertility is, I felt it was very broken in the way that experience was sort of done. And I kept thinking that, why is it like this, right? Fertility is such a personal journey, and it is actually a very, very complicated one in the sense that there's just so much coordination at hand, getting everything together in terms of appointments, doing so many tests, doing so many consults, scans, and why, and how can we actually streamline this and make it better. So that's how the thought of Luma came in, and this was almost sort of 2.5 years back. And then the question that I had was, am I the only one who's thinking like this? So typically, I'm very research oriented. So I basically sort of started with Apurva here, who you all met. We actually spoke to 200 women, okay, and 200 women we spoke to who are from different parts of India and who've been through this journey. Either they have done IVF, they struggled, they did IUI. Basically, they've been in the fertility journey. And what came about, and I remember the day we summarized that study after speaking to those women, it was very clear that I was not alone. That every single woman felt that the experience was broken. A common word that they used, even when they did not know each other, was they felt like cattle, and they felt like the doctor did their best, but there was just so much that could have been done in terms of making it easier for them, which probably was not being done, right? And I felt that maybe there is a systematic change that has to be done on the experience side, and of course bringing the best, right? So you have to bring success rates, you have to bring great embryology protocols. If you have that, but if you in that sort of structure give a valid experience, which is really taking the patient at the center of designing that experience, right? How would it look like? So I actually reached out to Dr. Rupin in the very early days of brainstorming, and it was very sweet of him at that point of time. I didn't come from the medical field, and he didn't dissuade me. He actually told me that, Neha, this is actually so much work that you have done, and he would keep meeting me. He would keep sort of asking me the right questions that I had to ask myself to be able to actually create this vision into what this could be, right? And I really thank him for all those early years and early sort of advice that he gave us. And moving on, I think what really shaped up in the last 1 year was a clinic, and where you sort of saw how this all came together. And the core of it was, how would we design it if the patient is at the center of designing journey, flow, experience, everything, right? So it is not optimized for the clinic, the PNL, the doctor, but it's actually optimized for that patient, right? So what we created is 55 friction points, and we tried to solve for each of those friction points by putting ourselves as the patient, right? And what you see basically, I think, three things that actually define what we stand for at Luma is one, empathy. And I'm very proud that our team, the doctors, are, I think, one of the most empathetic doctors I know, which I think is really, really needed in fertility. Second, I think, just the way the experience is created and the space is created. We wanted the space to not look clinical, not look sterile. Of course, it is sterile in the OT, but outside looks like, someone's house, a cafe, and really gets somebody's anxiousness level low, when we really know that they are sort of going through so much. And I think a concept that I saw, because I also benchmarked a lot of IVF clinics across the world. So personally, not as a patient but as an observer, I have visited over 50 clinics in Dubai, US, UK, Europe, and I kept the 55 friction points in front of me, and I started mapping what these clinics are doing differently, right? What is working well for them, what is not working well for them. Over the years, picked up a lot of advisors from these clinics who have actually given their inputs to design where we are sitting today, right? And I think what came about was Luma. And one of the key learnings there was, while the doctors are actually delivering clinically, and of course the embryologist is ensuring the embryology protocols and rates are sort of, higher than market standards, what do you do from an experience perspective? And the one answer was a care navigator, a care specialist who's a one-point contact in the entire journey, right? So this is a role that we've introduced, and this role is not just a care coordinator, which is what other clinics do, but in the true sense is somebody who is checking in, ensuring any queries are answered, and is actually available for the patient end to end. And we've also created an app which helps this care specialist and the patient to really track the journey, to know where they are. And we are hoping that all of this sort of put together really makes the patient feel like not a file but a person, and really makes them feel like they are actually supported through this sort of tough journey. So I'll stop talking because I can keep going on and on. And I also want to say that years of struggle and Luma story culminated into me having babies as well. So my girls turned 1 year last week, and we really think that for us the journey has really culminated into this beautiful clinic which is Luma, and very proud of the team that we have. So I met Dr. Radhika, I think more than a year back, and Dr. Vishesha and Chirag. And this team that we have is basically really, I feel like, stands for what Luma stands for, and very proud and very very happy that you all could all make it to this symposium. So Dr. Radhika, if you want to just quickly introduce yourself, and then I'll.
So I'm Dr. Radhika Sheth, and I'm the consultant clinical fertility specialist at Luma. So prior to this, I've had about 15 years of experience. So I was at a place called Morpheus IVF, where I was a general manager for including the clinical section for about 4 to 5 years, and after that I was at Cloud9 Fertility, which is at Malad, for almost 9 years. So yeah, that's me.
Thank you so much. Thank you so much, Dr. Radhika. So I actually have, a few questions, for you, and then would love for, Dr. Rupin to sort of, come in and share more on the topic that we have for today. So, Dr. Radhika, just I think, if you could just share what sort of made you, join Luma's vision, and how you sort of, look at it when it comes to Luma's vision coming into reality, you as a medical director.
So when I met you, Neha, and when you told me about what Luma stands for, I took to it very easily, because it's something that I felt was lacking, and I felt it was like fertility care redefined or reimagined. So not just from the clinical perspective, which of course is the core, but also from the point of view of trust, transparency as well as empathy. So I do believe that it's a combination of practicing evidence-based clinical protocols along with implementing all this with a deep humane approach. Only that can give a patient an excellent 100 times greater experience. So it's not just about taking up the role of a medical director, but it was trying to help build something along with the team, something that should have probably already existed.
Thank you so much. And on the clinical side, you mentioned sort of, there is a lot of focus on reimagining or redefining fertility. On the clinical side, what are the things that are contributing to what you're creating at Luma in terms of clinical side of protocols, etc.?
So like how it should be in any clinical practice, the patient is always the center. So all our clinical protocols, all the treatment advice, everything that is advised is very specific. It's very personalized or tailored according to the patient's history, diagnosis, or their own individual hormonal footprint. Second thing I think which is very important is transparency. So it's not just the lab, but also pricing that needs to be transparent. The reports that we give need to be transparent. The success rates, so we can't say 90% and 100% and things which are absolutely unbelievable. Uh, Other than that, technology. So I think that's the backbone of IVF. So the lab, as you must have seen already, has got superb equipment, superb infrastructure, the latest, I mean, up to date with whatever is available in the modern times. Other than that, I think introducing AI in the lab, whether it is, oocyte quality, sperm selection, embryo selection, I think all this is really going to go a very long way in delivering better patient outcomes. So that's what I meant when I said clinical.
Yeah. No, thank you so much. And I think just lastly, I remember you and I connected from the first meeting on patient centricity. What does patient centricity mean to you, and how you're looking at implementing it at Luma?
So, like what you mentioned earlier, Neha, so from your own journey, I mean, I think it's common knowledge that IVF can get pretty daunting, sometimes overwhelming, and the some injections are time bound, some things have to be done at a particular time, and all this can get couples very confused. So, to handhold them, we have care navigators who are kind of their personal companions. They are assigned for one couple, one care navigator for a couple. So they not only help in getting them to get appointments, getting the test done on time, sending them their reports, taking their all the paperwork, consents, checking in on them emotionally according to whatever their needs are from time to time. So I think they are like actual single point of contact for the patient, which I think is much needed, because very often the patient doesn't know whom to ask what. And then it can be perceived that a doctor is too busy for me and things like that, when actually that obviously is not the purpose of the entire treatment. Secondly, I think what we have started doing is actually drawing out a roadmap or giving them a fertility calendar, that this is the date when you should expect this and this is what you need to do when, so that they are not suddenly surprised that, oh, I had to do this and things like that. Also, we do not believe in disrupting the routine. So sending nurses home for injections, so that the patient's clinic visits are minimized. Also, their waiting time, we have designed it such that with multiple consulting rooms, their waiting time also, whenever they have to visit us, it would be minimized. I think all this is very convenient and supportive. And last but not the least, I think the Luma app, what you mentioned. So it's a wonderful AI tool. I think we should all show it to everybody. So it's like the Chat GPT version for fertility care. So if a patient has any fertility related question, the chat box, they can type it and the chat box gives a reply. And instead of a lot of googling about various topics that they may want to know more about concerning fertility, the tool already has it all incorporated. So for example, when a girl wants to do egg freezing, or if she's thinking about egg freezing, we often advise them a test called AMH, and they get the report, but then they don't know how to interpret it. So at Luma, we have got a Luma report where their AMH is plotted against what is considered normal, and so that they can take steps knowing that their steps have to be either immediate or soon or maybe delayed for some time. So I think what we are trying to do is build a holistic care with fertility obviously at the core, but surrounded by other adjuvant therapies, nutrition, taking care of mental health. So we have a clinical psychologist. So I think this is what we aim to do.
Well, thank you, Dr. Radhika. And I think over to you to introduce our chief speaker and Dr. Rupin.
So I don't know how to introduce Dr. Rupin Shah.
It's okay.
So, hi sir, thanks for coming. So, certain questions that I think most of us have in our mind. So, for your very long, you have advocated for paying more attention to male factor. But do you still think it is overlooked to some extent or neglected by us? So, what do you think is the reason that it is overlooked or neglected in mainstream fertility treatments?
While I talk about that, my laptop is in the corner. Just keep it out. There are two mails that I will read out from that later. The first one, actually, very interestingly, is a mail I received just there, right there, that black. A mail from the ASRM, the American Society of Reproductive Medicine. Their next meeting is going to happen shortly. And one of the keynote addresses there, that's what I read yesterday, so I thought I should share with you. The keynote address is by Alexander Giverkman, and it's titled The Health of the Male Partner, Impact on Fertility, the Mother, the Father, and the Child. So not just here, even abroad, bringing the focus onto the male is something which is contemporary. For men, it's interesting. When I was young, and that's a long time ago, Dr. C.L. Javeri, who was one of the pioneers, and I must say it's a pleasure to see my classmate here. He said that in those days, 50 years ago, men refused to give semen samples. And the way in which he would judge whether the male factor is contributing is he'd tell the wife, when you have intercourse, the next day morning come to me, and he actually did the post-coital test as an indirect way of assessing whether it was male factor or not. Today, by and large, it has changed. I still get idiots who've got married, divorced because of no children. And the third time or the fourth time, they finally do a semen report only to discover they're azoospermic. But by and large, in urban India at least, most men are now happy to give a semen sample. And more important, they want to feel included. A lot of men will come and tell me that, Doc, we just feel like sperm donors. The gynecologist or the IVF specialist doesn't look at us, just looks at the report, doesn't do any history, gives us one medicine, which is often a printed form of 3 antioxidants. Nobody is evaluated to see what can be done to improve my fertility. I don't know what I can do to increase our chances of pregnancy or how to support my wife. So it's very important that the male be involved at multiple levels. Otherwise, Luma will become lopsided. And of course, the women will have a wonderful experience and the men will continue to feel neglected. So I think it is important from multiple points of view that the male be involved. Now, as we were discussing before the meeting, and as you said correctly, there's often no treatment we can offer the male. But even then, today's patient, before I came here, he's got small testes, count of 6 million. Already the gynec has given 6 months of one antioxidant, second antioxidant. The man comes to me dissatisfied, dawai diya fayda nahi hua. Because he was not examined, he was just given a prescription. After I examined him and then showed him the Prader orchidometer, see, this is normal and this is the size of your testes. That is why your counts are low, and that is why maybe the medicine will help, but maybe it will not help. Then the acceptance of his condition and a timeline become more obvious that, okay, if in 6 months, 9 months you have not improved and an expert has seen you, has examined you, has looked at your size, has done your Doppler, has looked at your hormones and explained to you why you may not improve. Sometimes even that negative prognosis is important. Then the patient gets ready for the next step. But sometimes it can be the other way around. So I'm going to read you an email. And this is from 2019, so not so long ago. And says, Dr. Rupin, I was a patient of azoospermia. I met you in 2017. You operated me in 2018. So he had an obstruction. We did a reconstructive surgery called VEA. My sperm count was normal after 6 months. And 8 months later, I'm glad to inform you that my wife is having a normal pregnancy of 3 months. Now comes the main message. When I met you the first time, you told me that sperm are there and we can do something all the doctors in Mumbai, and remember, all these are my close friends, suggested me IVF ICSI and told me VEA, the surgery will not help. But you did it successfully, and now this is the most important line. I really thank you from the bottom of my heart. What we often forget, I will visit you personally. We all bring those dry fruits which made me become fat. So
If this is fat, what is this?
very often when we have IVF centers, we think the couple has come to us just to get pregnant. We forget that IVF is still the last step, their act of desperation. And most men would prefer to impregnate their wives naturally. Most women would prefer to have a natural pregnancy if possible. Not all men, I would say, in fact, maybe 80-85% of men we cannot help. Though by evaluating them, we can counsel them better. But there is this 10-15% of men who actually benefit either from reconstructive surgery or correction of a large varicocele or treatment of infection, and sometimes just lifestyle advice. I've got patients coming back 6 months later, sperm count has jumped. What did you do? Because I know the medicine I gave them was nothing, just some vitamin. Doc, we followed your advice. A few of them do. And we started exercising. We eat only vegetables. We've turned organic. I've stopped Coke and Pepsi. And I walk 7 kilometers a day. And boom, it changes. So 10-15% of the times, either we can help couples achieve a natural pregnancy by treating the male, and sometimes we can bring them from requiring an IVF to succeeding with an IUI. And if nothing else, we can help them understand why they have the problem. So to come back to your question, should men be treated? Are they willing? I think nowadays, yes, and they should be seen by an expert. Not that the expert will often help them, but he will help them one way or the other by giving them the right direction and sometimes by bringing about a dramatic change.
Yeah. So this is actually a real world example, the VA example that you
Sure.
gave, where not paying attention to that and diagnosing it right led to
Another real world example.
Yeah.
This was an army person who came all the way from the northeast. Low volume, 0.5 ml seminal azoospermia. And Priyank is jumping up and down. Low volume, did he have vasoplasia? No. He had ejaculatory duct obstruction. So the IVF specialist there said, oh, no sperm in the semen, no problem. We can do a sperm aspiration. And a lot of IVF centers have a one-track mind. Azoospermia means sperm aspiration, which is not necessarily the case. So they did the aspiration. They got sperm. They did the IVF failed. His wife divorced him. You're infertile, you can't have a child. I even went through IVF. I'm leaving you. Got remarried. And that's when he came to Bombay. And he actually had a blockage due to a cyst. And a simple surgery opened up the cyst. When he left, his sperm count was 60 or 70 million. And the second wife got pregnant. Had the IVF center, at the very first instant, given that opportunity, maybe it would never have ended in a divorce. That's a real life example.
very interesting. So, what are the common myths that men have about fertility? And how can clinics like us create more awareness or engage male partners more in treatment protocols?
Engaging men in treatment protocols will probably come from the clinic itself. If the clinic involves men in all the counseling, and I think a very important example to give them as a couple is to tell them 2 into 2 is 4, 4 into 1 is 4, 1 into 4 is 4. In other words, a very fertile male may compensate for a subfertile female, and far more often, because women are smarter, a super fertile female will very often compensate for a subfertile male. As you were saying, you've seen men with very low sperm counts achieve pregnancy, and the joke was during COVID, numerous couples waiting for IVF conceived just because they were at home having more frequent sex and just having the opportunity to do so. So that explanation that both have to be treated very important. Now, my gynec friends, most of whom have heard me talk on the subject very often, fall into two categories. One group who decides, no, Rupin is too busy, let's not send him the patient. It doesn't matter, we'll proceed to do whatever we do. And the other group who says that, no, until the sperm count improves, I will not treat the wife. Both are a little mistaken. It has to go hand in hand. You look at the age of the couple, the duration of infertility, the severity of the male factor. Are there correctable factors? Are there non-correctable factors? And balancing all that, one couple you will say, your count is only 3, 4, 5 million, but you're young. You've just been trying for 6 months. Nowadays, they come the moment they're deciding, even before they start trying. And a very, very interesting study, not one, many studies have shown that in young couples in the first 3 years of marriage, fertility is not predicted by sperm count, just because a clever wife compensates. So, young age. On the other hand, 35-year-old couple, married 8 years, Priyank has already treated them for 1 year and nothing has happened. And then they come to us, we'll tell them that now it's time to move on. So involving the male would start with the clinic. And if you have a sensible urologist, often I find that ART specialists don't want to send the patient because the couple goes there and for the next 9 months they don't see them because the urologist is giving them this thing, that thing, operating imaginary varicocele and the rest of that. But if you have a good counselor, he will help you, in fact, in the journey, help the patient identify which couple should wait, try treatment, and which couple needs to move on.
Right.
So the awareness starts with the clinic and with the doctor, and then we educate the patient.
Right. So how can clinics like us better integrate diagnostic tests and intervention for the male partner, both emotionally as well as medically, right from day one?
So the emotional part, I think, is try to involve the male in as much of even the female part as possible. There are some MCPs who said, okay, it's my wife's problem, now you manage. But there are enough men, I see more and more nowadays, who want to know, who want to be involved, who want to be informed as to what their wife is undergoing. The other way is, of course, to help men realize that the health of the male at the time of conception can impact the health of the baby. We all know that the mother's health will impact the baby, but very interesting study which was done in mice, monogenic mice, so they're all the same. One group of mice, they gave them pizzas and all the delicious stuff which is there in the coffee room. And the other group of mice, they put them on salads and stuff, which is what I'll eat tonight. And then they allowed the mice to mate. The same genetic background. The mice who were eating too much of fat and this and that became obese and diabetic. And these ones were, of course, healthy. The offspring of the obese mice had a much greater incidence of obesity and diabetes. And the healthy parented mice, fathered mice, were healthier. So we now begin to recognize that epigenetic modifications can actually change gene expression. And the health of the mother, yes, but even the health of the father can impact the child. So if we explain that to them, you can get them very much more involved. So maybe a little booklet, trying for a child, what can you do as a father?
As a father.
And then quote some studies so that they understand that they have a role to play. Yeah. Even though eventually they're just giving a sperm, but they can make it healthier.
Right.
And what do you, sorry, I just want to add, like what do you recommend from a diagnostic sort of journey, right? Which is, I think, the examination part, the example that you gave is a very valid one, and I don't think, anybody's doing it, at least at a fertility clinic yet. So is it at a semen analysis, post-semen analysis, if the semen analysis is not good? I mean, how would you recommend just going step by step on the male side, on the diagnostic?
Sure. So it starts with the semen analysis. And I'm sad to say that even today, the first slide in my male infertility talk is a slide that says that the first step in the evaluation of an infertile couple is a semen analysis. So semen analysis is a very, very early investigation. And unfortunately, even today, often the semen analysis is done after every scope that the gynecologist had has been put inside before the man is evaluated. Nobody here, this is for...
Yeah, not for us.
But I've seen that happen. So I think it's very important that the semen analysis should be done early.
Yeah.
Recognize that the semen analysis is more volatile than the Bombay stock market. So you need several reports over time. And that it needs to be correlated with the medical history and the physical examination. So that should be part of it. Like 2 of the patients I saw today, low sperm counts, physical examination very normal. So my counseling to them was that they don't match. Maybe it's still low, but maybe we need 1 or 2 samples before we label you as fertile or infertile. So the integration would be a semen report, a good medical history, sexual history, very important. Nowadays, with the modern lifestyle, more and more couples, very infrequent sex, and then they wonder why there is no pregnancy. So sexual history, very important, and a physical examination to correlate the findings with what we have. Then take it further to the more advanced tests which you have here, which are required in selected cases, which could be the genetics, could be the DNA fragmentation,
Hormone
it could be other specialized tests as required.
Super helpful. Thank you so much. Now we'll actually just open for Q&A. If there's anything that you all want to ask Dr. Rupin or even Dr. Radhika, we can spend probably 10 minutes on that. Post that, there are some refreshments, some healthier options, some salad as well. So yeah, if there's any questions, we can take that.
Why the name Luma?
Luma. Actually, it's a very interesting story. We wanted a name that represented guiding light, and we tried to see the name in various sort of Greek language, Arabic language. But I think we ultimately realized that moon is called luminous, and Luma, so guiding light. So that's how the name came about.
Nobody wants to ask which medicine should we give men with oligoasthenia?
So what's your take on, like, nowadays people rush toward, most of I have centers I'm talking about, people that think I have centers, like it's quite often like very low sperm count, oligo or stano-oligo. See, with one option that which will be suggested to the patient, to the male, but don't worry, we'll take sperm from the testis, only one sperm is required. What's your take on that? How good the chances are when you're taking the sperm from surgical retrievals? Are they good hope, or what I'll see, because why is it not offering a donor option if there's no choice, and straight away jumping to the surgical part, even with a very low sperm count also, cryptospermia, they will simply say, okay, go for donor, go for the surgical ones. But are surgical really helpful in all cases?
So I think that's a very useful question, because actually 2 or 3 questions built into that. First question is, if there's a very low sperm count, are testicular sperm superior? And the answer is probably no. If you have even very few sperm in the ejaculate, you can still do IVF ICSI with that. And that is important to highlight, because like you said, often I've seen centers saying, oh, sperm count is very low, you can't do IVF. Not true. In fact, there was one study on infertile men where for 7 months, every 2 weeks they asked them to give a semen sample, and a few of the samples had some sperm. They froze those sperm, did IVF, and the pregnancy rate was not as good, but reasonably good compared to the average for the clinic. So the first question, if there are a few sperm, should you do testicular? Only if 2 or 3 attempts of ejaculated sperm have failed. Then you come to zero sperm count. With zero sperm count, should you advise donor or TISA? It depends on the patient, because many patients, donor is not acceptable. Secondly, retrieving testicular sperm is a graded procedure. There's a needle TISA, which is innocuous. The patient will walk in, have the procedure, and walk out after 2 hours and have no pain, no discomfort, and a relatively very small expense. And 1 in 3, about 30%, will get sperm by that method. Of course, you can individualize based on various parameters, but roughly 1 in 3. Then, of course, there's microtester where you can split open the testes, and that is where your question becomes valid. So there we tell the patient that you have the option of donor sperm or simple needle aspiration or splitting open the testes and looking inside. Is splitting open superior? Yeah, in 5 to 10% cases where you don't get with the needle, you'll still get by cutting open and doing a microtester. Which one to do often depends on the patients themselves. For some patients, personal reasons, religious reasons, donor is not acceptable. And even if you tell them it's a 5% chance, they'll say, Doc, we want to take it. And the others will say, only 30% chance, we don't want to undergo all this, give us donor. So I think the bottom line answer to your question, which is a very important answer, is let us not put our prejudice on the patient that donor is better or surgical sperm retrieval is better. Give them the whole range of options, pros, cons, cost, disadvantage, then let them decide.
So then what are the chances when we do micro tests? Like what amount of patient out of 100, how many patients we might get sperms?
So again, it depends on patient groups. We know that if a patient had paradoxically undescended testes with azoospermia, we have a good chance of getting sperm, contrary to what we thought. Or somebody who had mumps orchitis. In other words, somebody who may have had a normal testes and later on that got damaged by illness or infection or surgery, high chance that somewhere a few sperm will still be present. So you'd give them a 60-70% chance. But someone who since birth had no medical problem, which means by birth there were no sperm, probably there is some genetic factor, even if we can't detect it, and there I would give them only a 25-30% chance. So on an average we tell them 30-40%, but we can separate it out this way.
Suppose we have a couple, like wife is 30 years and AMH is very on the borderline, and husband's count is like 2-3 million. So will you still wait for like improving the sperm count, or would you suggest them to go for IVF for HC?
So it will depend on whether they have an obviously correctable factor. Because wife is borderline, we don't want to waste time. But if his sperm quality is quite poor, 2-3 million, motility poor, maybe the sperm morphology is poor, and he has a large grade 4 varicocele, then studies have shown that correcting the varicocele not only improve the sperm quality, but they've compared two groups, severely low count and varicocele, directly undergoing IVF, low count varicocele operated, then doing IVF, and the take home baby rate is higher after correcting the varicocele because the sperm quality improved. So here again, examining the male becomes important. If there's a correctable factor, then we might take a chance with the AMH, though Radhika will hate us for it. But she'll probably do a cycle and freeze those eggs and do one more cycle.
I do that.
So that she has more eggs to play with. But if there's no correctable factor, then in fact the uroandrologist should have the confidence to tell the patient, I've seen you, there's nothing that we can correct, your counts are low, they may deteriorate further, do not waste time. So that is where a good synchrony is important. So in fact, as I joke, I attend more IVF meetings than urology meetings so that I understand how the ART specialist is thinking.
So,
No questions?
No questions, yeah.
I just want to ask you about the fructose test negative.
So
Normal count and low count or
so again, it's two questions here. Normal count, low count, fructose doesn't matter. It doesn't impact anything. No count and fructose makes a big difference. However, 90% of labs don't test for fructose. They just write fructose positive. And I'll tell you why. Because in the true cases where fructose is absent, the semen volume is very less. classic cause for absent fructose is either vasoplasia, congenital, or ejaculatory duct obstruction. And in both the cases, the semen volume will be 0.5 ml. To do a test for fructose, the test is called a Selivanov test. You need 0.5 ml of semen, 5 ml of resorcinol, and you boil it together. Now the patient has produced only 0.5 ml. They're checking for sperm, they're checking for pH, they're checking for many things. At the end of it, they don't have any semen left. Therefore, an honest lab will write QNS, and time and again they will write fructose present even when it's absent. So that's why if fructose is an issue, I will send to Fadke's lab, because they have a different method of doing it where their fructose report is accurate. Now, if fructose is really absent in an azoospermic man, that is these two things, vasoplasia or ejaculatory duct obstruction. In oligoastheno, don't even look at fructose, not relevant.
How it becomes positive later?
How it becomes?
First it is negative. And then later
They report positive because they don't test. तो typist को पता है fructose positive type कर दिया.
no, negative and later it becomes positive.
Negative become positive is because you must have changed the lab. Honestly, because I see it again and again. Priyank would have seen it again and again.
Maybe inflammation and infection or
Rarely, yes. If there is an obstruction which got corrected, it could. But that's less common. More often we'll blame the pathologist.
one patient from Goa had come to me, 5-6 women. Sometimes it was positive, sometimes it was negative.
So that you have to correlate with semen volume. If somebody has a semen volume of 3 ml and they say fructose negative, I would doubt the lab. Because the bulk of semen volume comes from the seminal vesicles and fructose comes from the seminal vesicles. So they tend to go hand in hand. So you sometimes need to look at other parameters to interpret one parameter.
Would you couple who comes with premature ejaculation? What can you? I mean,
Okay, so again, multiple questions in one. There are basically there's different types of premature ejaculation. One is antepartum. During foreplay, the male ejaculates. Therefore, fertility is not happening. The other is where he penetrates and then ejaculates early, where fertility is possible, but sexual satisfaction is the issue. So the management can be different depending on the priority being fertility or sexual dysfunction. For premature ejaculation, in general, we have oral medication, several drugs. We have anesthetic agents that reduce the sensitivity and allow them to last longer. We have psychosexual techniques like stop-go, squeeze technique. There are surgeries also possible, which we don't recommend. And where fertility is an issue, sometimes simple insemination can solve the problem. And if it is an acquired problem, which means you're normal, and suddenly develops premature ejaculation, sometimes that is because of a prostatic infection, which we look for and correct. And sometimes in older men, they actually develop an erectile dysfunction. So they need more stimulation to become erect. Therefore, they're ejaculating early. And you treat the ED and the PE is solved. So it's a whole basket of cases.
What's the role of genetic, basically understanding the genetic testing in a male in cases of like severe oats or some where you're feeling that the patient is suffering from azoospermia and we are thinking with the testicular sample or very small sperm which you're getting, whatever we're getting, and thinking of going for a genetic testing also, going for karyotyping, basic karyotyping, not going for directly to the AZF gene, but focusing on the basic part. What's your take?
If you have severe oligo, in fact, karyotyping is less likely to be useful, and testing for AZF deletion will be more useful. Karyotyping can sometimes be a cause for low counts, but more often it will be a cause for recurrent pregnancy loss. So if somebody has a count of less than 1 million total sperm count persistently, and this cutoff differs according to different guidelines, you could do an AZF testing. The significance there would be only in counseling the patients. If a patient has a count of 1 million and is planning ICSI, and you do a genetic test and you find a deletion in the AZFC location, then you will counsel the patient that if IVF succeeds and you have a male child, he will inherit the same problem. On the other hand, if somebody has no sperm and you find an AZF A or B deletion, then you will tell him that we will not even do a sperm retrieval because we will not find sperms. And that's a prognostic utility. And if he has an AZF-C deletion, we will tell him there's still a 30-40% chance of finding sperm, but again, your offspring will inherit it. If they're very small testes and azoospermia, then karyotype becomes important. And till date, I've seen 4 or 5 patients, men, whose karyotype was 46XX. They were actually women, genetically. But a small segment of the Y chromosome, called the SRY gene, SRY, gets attached to the X chromosome and converts this 46XX female into a male phenotype. But he will never have sperm in his testes. Or often we may find Klinefelters, where we can still get sperm, interestingly. In about 20% of men with Klinefelter syndrome, 47XXY, we can still get sperm from that tiny testes. So both are important. Nowadays, many centers are doing whole genome mapping. How to interpret that is still not very clear. In the future, I think that will be a very, very important test. But so far, we don't know that this rare single gene defect, what does it translate into?
Great, so we can take the questions over one-on-one when we are just, hanging out over some refreshments.
Yeah.
Thank you so much everybody for being here. It was truly an honor to host you all. And thank you, Dr. Rupin.
My pleasure.
It was really, really great having you for the last 1 hour, learned so much. And
I have to go home and read about AZF. What is AZF? Azoospermia factor.
Yes. No, thank you so much. And thank you so much, Dr.
Thank you.
Radhika.
Thanks.
Thank you.
Thank you, everyone, and thank you for inviting me.